Good afternoon, everybody. Mordechai Levi here, one of the Project Echo Nevada geriatricians on staff. Welcome to our geriatric clinic this month. Today we're going to be talking about dementia screening. But before that, I was going to kind of give everybody a short kind of 5-minute tutorial on the Echo model for those of you that are unfamiliar or have never been shared. We haven't shared that information with you in the past, just so you kind of know what we're trying to do here and what we're doing. But before we get started, we'll start with introductions. Today we're going to have everybody introduce themselves that's logged on first, and then we'll kind of introduce ourselves here in the room. And so I think we'll have Troy help us facilitate those introductions.
Yep. So Alan, you want to start us off?
Sure, thank you. I'm Alan Fisk. I'm in the Elko office. I'm here for technical support, and if you have any technical issues, please get a hold of Troy or myself, and we'll see if we can help you with them.
Thank you.
Thanks, Alan. And then our group at Washoe County Public Guardians, I'll take you off mute.
Natasha Kane, case manager.
Allison Fitz, guardian case manager.
Terry Galvin, guardian case manager.
Excellent, thank you. Just writing my note here. Ashlyn Call, please go ahead.
Hi, my name is Ashlyn Call. I'm a PA and I live in the Las Vegas area and I practice in geriatrics.
Cool. Is it your birthday?
It was last week, yeah.
Happy belated birthday.
Thank you.
It's just a phone or a number showing up, 15775-73802. I'll take you off mute. Could you introduce yourself?
This is Kieran Madden. I don't know if I'm on or not.
Yep, Dr. Madden, we can hear you.
Oh, okay, great.
Thanks so much. Good to have you today. Next is Anna Peterson. Please go ahead.
Yeah, hi, I'm Anna. I'm a nurse practitioner student at UNR, joining you from Incline Village.
Excellent, thank you. Somebody joined by their iPhone. I'll unmute you if you could introduce yourself, please. Okay, maybe we don't have a microphone for you, so I'll write something through the chat so you can see that. If you could just write in your name, your credential, and your location for us so we can have that for our records and know who you are, that'd be great. Move on to Landon. Landon, Lindsay, nurse practitioner student in Reno. Thank you, good to have you. And last is Caitlin Riley.
That might have been for the iPhone.
But no, it was the other.
Oh, never mind, thank you.
Hi, I'm Caitlin Riley. I'm a DNP student at UNR, but I'm located in Auburn, California.
All right, thank you.
Yeah, thank you.
Cool. And so we'll start introductions in the room. I guess, Troy, you want to introduce yourself first?
Yeah, sure. So I'm Troy Jorgensen. I am the program manager here for Project Echo Nevada.
And I'm Mordechai Levi, one of a UNR med geriatrician, one of the subject matter experts here for our geriatric echo clinic today. And then Monga.
And this is Monga Sharma. I'm a UNR geriatrician.
And Patty Swagger, I'm with the Sanford Center for Aging.
And then we have two other people in the room with us as well today. And if you guys wouldn't mind introducing yourselves.
My name is Doris Alukam. I'm a nurse practitioner student, psych mental health at UNR.
My name is Michael Fry, and I'm a family practice practitioner student at UNR.
Cool. Well, I think that's everybody. So welcome everybody today. We're glad to have you here. Before we kind of started with the presentation today, I wanted to see if anybody had any questions from previous clinics or had any patient cases or questions they kind of wanted to present to the group so that we can kind of help with those. We'll kind of leave a few moments of silence as kind of people think about that.
If you do have something, just remember you can unmute yourself with the microphone icon in the lower left corner of the Zoom window or write in through the chat box.
All right, so it's been about 30 seconds. Haven't heard anything from anybody, but if anything comes up while we're talking, feel free to interrupt, raise your hands, talk through the chat as we get going. Otherwise, we'll kind of get going with the presentation. The first part of the presentation today will kind of help potentially explain a little bit better why we always stop and ask for cases prior to starting our echo clinic. And then the next portion will be talking specifically about dementia screening, and we'll go from there.
So this is our disclaimer, just reminding you that we do record all of these clinic sessions. So if you don't want to be on video, just let us know and we can edit you out. Also, just a reminder, if you do present a patient case, not to disclose any HIPAA protected information, no protected health information, anything like that, please.
Cool, so no conflicts of interest related to my discussion today. And the first part of the discussion, and this includes both the intro and the second portion. One of my other jobs, besides kind of just being the subject matter expert here at our geriatric echo clinic, I'm also the medical director of our entire Project Echo Nevada program. And so I know a little bit about kind of how Project Echo works. And so what I'm doing today is kind of just sharing with you some of the knowledge that I've gained working with Troy over the last little bit over a year, as far as the way Project Echo originally was created and intended to work. So today, just kind of in this first 5 minutes, we'll be giving a quick Project Echo Nevada overview. We'll talk to you about what the hub and spoke model is, and then talk about the echo clinic anatomy, essentially how we like to structure each of our clinics every time we meet. So Project Echo stands for Extensions for Community Healthcare Outcomes. It's a global telehealth platform that we're all actually participating in right now, so that's pretty exciting. Project Echo originally started in the early 2000s down in New Mexico. There was a physician who had a hepatitis clinic, had really long waits at his hepatitis clinic. People would get worsening liver disease, die while they waited to see him, sometimes up to 8 months. Wondered if there was a better way. So we went to all of the primary care providers referring patients to him in rural New Mexico, asked them why they weren't treating the patients themselves and making the referrals. He learned that they didn't feel comfortable treating it, both they didn't have the knowledge and then didn't understand the medications. So he set up clinics like this. His were initially twice weekly, so much more frequent than ours. And he was able to kind of tele-mentor them and teach them how to take care of these hepatitis C patients. And this was all before Harboni, before Gilead came out with Harboni, which makes treating hepatitis C much simpler. And so essentially was able to publish a paper in 2009, or 2011, excuse me, showing that using this echo model, the people being taken care of in rural New Mexico had just as good outcomes as he was able to produce in New Mexico. And so from there, kind of Project Echo exploded, went all over the world. Currently, we were the 4th people to copy the echo model back in 2012. Initially started with just 4 clinics, but since then we've kind of evolved to the 8 clinics that you see there on the right, with Geriatrics being one of them. So currently we run at least 10 clinics a month because our medication-assisted treatment and our pain management run twice a month. All of our other clinics currently just run once a month. And so essentially that's kind of what we're currently offering. Everybody that's logged on today to the geriatric clinic is more than welcome to log on to any of our other clinics as well. They all offer CME if you complete the evaluation at the end. So does anybody have any kind of questions about that quick overview of Project Echo and our kind of current clinics that we have? No? I see Ashlyn, thank you. So moving on to the hub and spoke model. Essentially, sorry, it's cool. So the hub team essentially are the people that are in this room, what we call the echo chamber. It includes the facilitators, the people that kind of make sure the communication is happening nicely and easily, making sure we're respectful of everybody's opinions and thoughts. The hub team also includes the multidisciplinary team of subject matter experts. Umanga and I and Patty all are part of that team. For those of you that have logged on to previous clinics, we often have a pharmacist, a social worker, and a nurse partner as well. Unfortunately, today they weren't able to join us. And that kind of describes the hub team, the subject matter experts. Then there's the spokes, which are essentially the multidisciplinary care teams from urban and rural Nevada. And often from farther away. Often we have people participating from Eastern California. For some of our clinics, we have people participating from across the country. And so essentially we don't limit who can essentially participate in our clinics, but our main goal is to access those multidisciplinary care teams in urban and rural Nevada. And it's important to kind of emphasize that using this hub and spoke model, we're not the traditional telemedicine model where you have a provider seeing a patient, one provider seeing one patient at a time. This is really kind of providers speaking to providers, where kind of we're providers here in Reno in our kind of academic-based setting, and you all are providers in your respective settings. Lots of nurse students as well, which we're happy to see kind of learning how to take care of the specific populations that they're worried about. And so we're here to kind of help with that learning. Any kind of questions you have during your patient care or even in your classes, we're happy to address and kind of give you our perspective on it. But not only are we going to give you our perspective as the hub team, what we really want are all the spoke teams to also kind of include their opinions, their thoughts. You guys all deal with similar things all the time and have equally valid opinions and options that we definitely want to encourage you all to share amongst our clinic. To kind of more to talk about our specific geriatric clinic, I've kind of listed out all of our current hub team members. Patty, Umanga, and that's me, Mordechai, kind of all introduced ourselves. And as I mentioned, Kelly McMillan is our social worker, our behavioral health expert. Then we have Leslie, it's Baker, not Backer, I misspelled that, I apologize. She's our pharmacist. And then Kelly Presser, who is our nursing partner on our team. And then, like I mentioned, you all of our target audience are spokes. And then I always like to reemphasize that this is not the traditional telemedicine model. This is really providers speaking to providers. And I think, and then we move on to the Echo Clinic anatomy. So essentially, we break up all our clinics very similarly, except for this specific clinic where we're kind of giving an extra didactic talking about this specifically. We like to make sure we always start with introductions, have the spokes go first and then the hubs. Usually we do the hub, the people in the room present first, but I think we're going to start changing it around and having people start introducing themselves as spokes first. Usually this takes 5 to 10 minutes depending on the number of participants. In our clinic, we like to have cases next. For those of you that have participated before, we don't have too many cases come through. I'm hopeful that this orientation or this presentation will kind of help encourage you guys to present cases. If you guys go onto our website, we have a link for a case presentation form where we ask you to fill it out. You can fill out as much or as little as appropriate. Essentially, the main thing we need to know is the question that you have for us and any kind of pertinent information that we might need to kind of help with your question. The way that we kind of set up the form is just kind of the way we want you to present the case in clinic, so we're not trying to make it more difficult. And we'd like to spend about 20 minutes per case or 20 to 40 minutes if we get 2 spokes to present cases. And then every clinic, as you know, has a didactic. Today it'll be about dementia screening. Today my didactic will be within the 15 to 30 minute range, so we may have some extra time at the end for lots of question and answer if any cases kind of pop up or any questions arise. And I think that is my introduction to Project Echo. There's a lot more to Project Echo. That was kind of the quick rundown. Talked about how Echo started, talked about the facilitation model, talked about kind of the hub and spoke model, and then shared with you kind of how we like to set up our clinic with the anatomy on why we run things the way we do. So what questions can I answer about any of that? Do you have any questions in here? No?
So this is free to anybody?
Free to anybody, you got it. All e-clinics, yep. Yep, and then CME, we have nursing, pharmacy, and MD/DO credit. For our specific clinic, we also do we get long-term care?
Yes, for today, yes.
Yeah, so for today, we also have long-term care credit for those of you that need that as well. And then if we can get and then it's kind of tough to get social work credit, but we're happy to provide certificates for anybody that's a social worker that wants to submit that certificate to their board. We have varying luck with getting things approved before our clinics. Is that a fair statement, Troy? Mm-hmm. Okay, thanks. What other questions can I answer? Good question, thank you. All right, so we'll get going. So today I'm going to give a talk about dementia screening, and I think this is going to be the final one of our dementia series. Is that right, Patty?
Yes.
Okay. We've had a short dementia series here in a bit, and I'll kind of share with you all of the dementia stuff that we've done over the last 2 years in a slide or two. My objectives today are kind of just to describe different tests that can screen for dementia, and then also to discuss potential limitations in screening for dementia. So try to keep it pretty simple. Hopefully we'll meet the objectives at the end. Quick outline. First slide is going to just kind of review previous echoes on dementia and the content that we included in them. Again, going to share my definition of dementia. Then I'm going to talk about who should we screen for dementia with some things to consider. And then specifically, I'm going to talk about those 3 screening tools: the Mini-Cog, the MoCA, which is the Montreal Cognitive Assessment, and the 6 CIT, which is essentially a 6-question clinical item questionnaire. So just to make sure we're all on the same page, when talking about dementia, the definition that I'm going to be using today is it's a progressive syndrome characterized by acquired losses in cognition and emotional abilities that are severe enough to interfere with daily functioning and quality of life. For any time that you have any issues with cognition or emotional abilities that are not severe enough to interfere with with daily functioning and quality of life, often we just call that cognitive impairment rather than a dementia. To kind of spoke of dementia as being a syndrome, to kind of help distinguish between a syndrome and a disease, I have those definitions as well. A syndrome is a group of symptoms often seen together, or condition characterized by a set of symptoms seen together, whereas a disease is a process of specific signs and symptoms that has a known cause and known consequences. Last month, Dr. Hagen gave a discussion on diagnosing different types of dementia, and so essentially, to kind of bring that into the context of these definitions, essentially dementia being a syndrome with multiple different causes, such as Alzheimer's, Lewy body, frontotemporal dementia, all have their own specific disease processes. It's just that their signs and symptoms can have overlapping, which is why we kind of loop them into a syndrome as well. And so that's the definition of dementia that we'll be using today. Previously, we've had 2 essentially series on dementia. We had one from July 2018 to October 2018, where we discussed polypharmacy, delirium, dementia, specifically focusing on the neuropsychiatric symptoms of it, and then also had a discussion on competence versus capacity. Right now, we're finishing up another dementia series. We've had multiple discussions about dementia over the last few months. Started with creating a person-centered care plan for persons with dementia and behavioral expressions. Then we talked a little bit about best practices for prescribing or de-prescribing medications used to treat dementia. We also talked about best practices to support ADLs in persons with dementia. Also talked about ethical dilemmas when caring for somebody with dementia. And last month, we talked about the diagnostic criteria for different types of dementia. And so as you can see, we've done lots of dementia discussions, focused a lot of our time on that. We're here going to talk about it again. So going back to kind of our topic for the day, talk about who should be screened. When just talking about guidelines, universal screening is not recommended by the United States Preventive Services Task Force. But you'll also see that in your Medicare annual wellness visit that you do for your patients every year that have Medicare, they all have a Mini-Cog. And so that is a type of dementia screening. And so even though I don't think there's an official society or task force that would recommend universal screening, lots of them recommend screening, especially if you have certain clinical cues. I've listed some of those on the right. Often I think about screening for dementia when somebody has consistently missed a lot of appointments, potentially they're forgetting to come see me. If there's issues with medications, either issues with adherence, that's my preferred word, to compliance, or if there's lots of medication errors, you don't seem to be able to communicate as well with the patient as you have been with regards to their medications. Sometimes you see behavioral concerns or behavioral changes, specifically personal hygiene or changes in people's personality. Sometimes weight loss can be a sign that people are having some cognitive issues. Obviously, weight loss has a very large, broad differential, and dementia shouldn't necessarily be the first thing you think of when somebody's losing weight. But often, weight loss can be the first sign of somebody having some cognitive issues. And then it's also important just to kind of offer a screening, especially if the patient or family mentioned concerns. people have high value on their memory and their cognition, and making sure that we're appropriately addressing those things is really important to maintaining that therapeutic relationship with our patients. Are there any other clinical cues that you guys have used in the past, both in this room and kind of online, for things where you were wondering if somebody had dementia or some cognitive impairment?
Little car accidents or little mess ups in the car, or, you know, forgetting things related to driving.
Cool, that's a great one. Yeah, thank you.
Yeah, I was gonna say forgetfulness.
Okay. Yep. So we in the room we talked about being forgetful, you know, and so we all forget things at times, but essentially, especially if we start to forget the same thing multiple times, continue to misplace things that we're not used to misplacing, then those could also be early signs of some cognitive impairment. Anything else from the nurse practitioner students that are online? Things that you've learned in school, or things that you've experienced yourselves with family members or other people you've taken care of? All right.
I have one.
Sure.
In the ER, a lot of the times it's not family. For a lot of the older vets, they don't have family. So it's really the caretakers and the assisted living facilities that come in with behavioral changes.
Cool. Thank you. Great. Yeah, great point. Yeah, I wrote family or patient or family, but yeah, essentially it's anybody who cares for the patient, who has good interaction with them, friends and family. Friends are also a good one. Sometimes I have patients where essentially their only interactions are with their neighbors. And so I end up having to talk to their neighbors, and they're able to give me a great history of the changes that they've had over the last few years to kind of help me understand what's going on with the person I'm trying to take care of. But yeah, that's perfect. Thank you. So essentially, once you decide that you either have had these clinical cues that maybe I want to start screening for dementia, what do you do after that? Essentially, you got to get a good history. That's kind of what we say about almost every disease, and it kind of goes. It's kind of double-fold for dementia, because if you don't get a good history, it's really easy to get the wrong diagnosis. What's most important when getting a dementia history is you really want to know the onset, how long it's been going on, or the duration, and also the course of the symptoms. Has there been any fluctuation? Has there been any changes in those symptoms? When talking about those three specific things, you're kind of looking to see if things are progressive, whether they've been happening over months to years, whether they're acute, hours to days, or subacute from days to weeks. A question to kind of throw out into the audience, if you're getting your history and you find that these cognitive changes have happened acutely, over hours or days, would that make you suspicious of dementia or less suspicious of dementia?
Less suspicious.
Less suspicious.
So in the room here, I got less suspicious. Does anybody mind sharing why they think less suspicious?
UTI, any kind of infectious process can make acute mentation change. Also, some of these older people have issues with oxygenation. Hypoxic situations can also alter mental status.
Good, exactly.
Just to name a few.
Yep, exactly. Yep. So anytime you have an acute change, you're really thinking of a delirium rather than a dementia. Want to make sure you're not dealing with acute mental status change. Secondary to infection, UTIs, hypoxia was mentioned, even things like a heart attack, missing medications, new medications can all cause these acute changes. Electrolyte imbalances, specifically sodium, calcium, your BUN and your glucose are all very important electrolytes that can cause mental status changes.
This question here, Dr.
Sure. So there's a question, do you find that patients are good sources for history in these circumstances? So does anybody want to answer that for us? I guess Landon, was it Leslie?
Lindsay.
Lindsay had a question for us. Do we find that patients are good sources for history in these circumstances? Does anybody have any experiences that they'd like to share? Is it Anna? Any thoughts for us?
I've had patients that have brought up to me that they think they're having like memory loss and issues, but I think that definitely other patients are a little bit oblivious to the fact that they are kind of having memory issues.
Good, great point. Yeah, thank you.
I always thought that was one of the definitions, not a definition I should say, but one of the key hallmarks of dementia is that they don't know that they're having it and that they're in a little bit of denial about it. And so in my practice, majority of the time, it's a family member that comes in, or I'm talking to them and they don't seem to understand things. And so I administer the Mini-Cog, and that's when we're like, whoa, you definitely got some memory issues going on. And they can't tell you how long it's been going on. And so, yeah, I haven't found them to be very poor historians because most of them don't think they have it.
Cool. Yes, thank you for sharing. Yeah, so kind of what we're referring to now is kind of people's insight into their disease, you know, how aware are they of their cognitive issues. And so I think the most important thing I want to say is always, it's very important to elicit the patient's perspective. Even if the patient's a poor historian or a limited historian, we always want to see what their take is, even if we can't necessarily get much from it as far as a plan. And I think essentially what the question was bringing up is it's really important to get corroborating information. Anytime you're worried about cognitive issues, your patient is kind of a main source of information, but they shouldn't be your only source of information. You need to kind of confirm what they're saying with family members or with caregivers. Often there are certain types of dementia where people confabulate, or essentially they make up stories on the spot, and it can be very difficult to assess if it's true or not unless you kind of know exactly what had happened in the past or have somebody else to kind of confirm that story. And so whenever we're dealing with dementia, we're not only getting history from the patient, we're getting a history from the family member or caregiver. Hopefully one is available. But yeah, that was a great question. Thank you. The subacute, when getting a good history, is always tougher. Sometimes I always kind of continue to treat that as a delirium rather than dementia. It's not until we've moved into months or years of cognitive issues that I really like to think that somebody may have dementia. Also important to get, are there any associated events with the symptom onset or course of symptoms, something like a stroke, hospital stay, medication changes. When people have strokes, it really increases their risk of getting a vascular dementia. When older patients are in the hospital, they're very likely to get delirious. When people are delirious in the hospital, they're 12 times as likely to get dementia in the past. And medication changes, we can all be sensitive to those, but those of us that are older can be especially sensitive. And so knowing if there's any temporal relationships with the symptom onset and medication changes are also very important. Also important to get a good family history, past medical history, social history, specifically things like alcohol, recreational drugs, and then making sure you get a good history regarding the over-the-counter supplements. There are lots of over-the-counter supplements and herbs that can potentially cause harm to anybody, and so it's good to get a good list. Once you get that history, you feel like you might be dealing with a dementia, you always want to make sure this is going to be another disease process getting into your differential diagnosis. You want to essentially make sure there's not a psychiatric disease or delirium going on. Two potential screens, which we won't talk about today, are the PHQ-2 or PHQ-9 for depression. There's also the geriatric depression scale. And then delirium, my favorite is the confusion assessment, the 3D CAM, or the 3-minute diagnostic assay confusion assessment method. Delirium is almost always caused by an acute medical condition, and you should kind of look for things to reverse that. And so anytime I think of dementia, I always want to make sure I'm not missing a psychiatric disease, especially depression or delirium, because those are also syndromes that can have overlapping symptoms with our dementia. The labs to consider, making sure they don't have an infection or significant anemia or other kind of CBC abnormality, making sure their CMP looks normal, making sure there's not any acute renal failure, hepatic failure, electrolyte abnormality, sodium, potassium, BUN, and glucose, making sure their B12 level is normal, and making sure their thyroid looks good. I'm always wanting to make sure you check that free T4 level as well, especially if they're not on thyroid replacement, because sometimes, very rarely, but sometimes you can have a normal TSH and abnormal T4. That's clinically significant. So anybody have any questions about essentially once you decide you're going to screen somebody, kind of what you're going to do right after that? All right, we'll keep going. Thanks. And so once you decide that you're not dealing with a depression or delirium, you've gotten your good history, somebody is concerned about their cognition, or you've kind of picked up on another one of those clinical cues, there's a couple things that you want to consider before picking your screening test. Essentially, you want to make sure that you know their primary language. Giving somebody a test in a language they can't read or understand isn't fair and isn't validated. You want to assess their literacy, both their ability to read and their health literacy. Often, these can all play roles depending on the exact screening method you use, and then their educational level as well. We'll talk about these here in a second, but people that have limited education or may not be able to do all of the things that a MoCA test might think you should be able to do at your age. And so we have some variations on that testing that I'll go over as well. So this is a list. You guys might recognize this if you were here 13 months ago during my last dementia lecture. But essentially, this is a really big list of validated screening tools for dementia. That you can see that the full scene MMSE up there, that one is probably the most well-known. I think the things to note are the sensitivity and specificity on the right there. Essentially, you want to look for a test that's sensitive, meaning you can easily rule out something, and a test that's specific means that you can rule it in. And so a test that's very sensitive means if they score essentially negative on the test for dementia, they almost very unlikely to have it. As you can see, the MoCA. It's all right. The MoCA over here. It's okay. I don't need to use it. The MoCA test is the most sensitive, and the 6 CIT score is the most specific, which is why I kind of chose those to talk about today, to kind of maximize your time and your ability to find and diagnose or find and consider dementia. And then I'm going to go over the Mini-Cog and kind of step-by-step detail on how we do it in case you're unfamiliar. Does anybody have any questions about these specific screening tools before we kind of move on to them in those three in more detail?
Is the MoCA copyrighted? Because the mini mental status exam is, and so my company had to stop using it and switch to the Mini-Cog, and so I just want to know if the MoCA.
Yeah, so that's a good point. Every time you document on the MMSE, you got to pay them $1. And then the MoCA is not copyrighted; it's free to use. But starting in September 2020, and this will be on the slide, in order to download new sheets from the website, you're gonna have to have completed a $125 training. And so essentially, they're offering a training now to make sure that people are administering the MoCA with fidelity and appropriately. And so the MoCA is free, but you will need to do a training every 2 years. The first time the training is $125. They say after that it's going to be half price for subsequent trainings. But yeah, great question. And the 6 CIT is free. Nobody. You don't have to pay anybody for that. That's also why I don't talk about the MMSE, is because you got to pay for it. So. Great question, thank you. So now the next few slides are going to be about the Mini-Cog. Some quick highlights. This screens for dementia. It's almost always followed by another test. This can be offered in multiple languages. This is a 3-minute, 2-item test. It's scored on a 5-point scale. You use the universal Mini-Cog instrument, and essentially you offer 3 points per word remembered. You ask them to remember 3 words, and then you get 2 points total if you get a correct clock. So step 1, when you're doing the Mini-Cog, is making sure you have the patient's attention. You want to instruct the patient to listen carefully and remember the 3 unrelated words, and then repeat the words back to you so that they know they heard the words correctly. You may want to say something like, what we're going to do next will take some concentration. Ready? I find anytime these instruments give me quotes, I tend to use them verbatim as much as I can. That's usually how they validated the instrument, was making the people that did the assessments follow a script with these specific quotes. So step 1 is making sure you're getting the patient's attention. You don't want to give a test to somebody that's distracted by the news or their family or an event that is otherwise going to limit your ability to assess their cognition. Once you get their attention, you want to ask the patient to repeat the words to ensure understanding. So essentially, once you're sure they're paying attention, you ask them to say 3 words that you want to remember now and later. The words are banana, sunrise, and chair. Please say them now. And so essentially, you want to give them 3 tries to repeat the words. You may repeat the words each time for each try. And if they are unable to repeat the words back to you after 3 tries, you just go directly to the clock drawing. So essentially, you ask them to remember 3 words. You give them 3 chances to repeat the words back to you. And if they don't repeat the words back to you after 3 times, you just move on to the next step, which will be the clock drawing. Does anybody have any questions about this step? So step 3 is the part where you ask the patient to draw a clock. You can provide the universal Mini-Cog instrument. You can just download it off at the end of my presentation. There'll be the website so you can log on. But essentially, it's just a piece of paper with a circle on it, and that's the main instrument that you need. And then the other parts of the instrument are just to score it. But essentially, you ask them to please draw a clock in the circle. It's acceptable to provide a sheet of paper with a circle already drawn, as I mentioned. And then you ask them to put all the numbers in the circle. So once they put all the numbers in the circle, or when number 2 is completed, you ask them to show the hands to show 10 past 11. You give them 3 minutes to draw the clock. And if they haven't been able to draw it after 3 minutes, you just move on to the word recall. In order to get a correct clock drawing, they don't care about the lengths of the hands. They just care about making sure all the numbers are in the general right position, they're not missing numbers, and that the hands are showing the correct time regardless of the length of the arms. And that's kind of how you would look at the score. And I think it's, and correct me if anybody does this differently, but it's either all or none for the clock draw. You either get 2 points for getting it correctly or 0 points if any of those things that I mentioned are wrong. So moving on to the final step, you'll ask the patient to recall the 3 words. The script they give us is what were the 3 words I asked you to remember. And the important thing to do is, even if they couldn't remember the 3 words during those 3 trials in the beginning that you were asking them to remember, you still want to give them the opportunity to remember the words here in step 4. And so essentially, you get 1 point for each word that you remember on this step 4 second attempt. Or 4th attempt, depending on how many times they took them to try, and then the clock draw as well. Essentially, if you have if you get score 3 or more points, you're probably normal, but anything less than 3, there's concerns for dementia, and you may want to consider following it up with another cognitive assessment that's more in depth, I'll talk about the next steps here at the end of the presentation, but it's also important to do things like a functional assessment and safety assessments as well once somebody potentially screens positive for dementia. So these were the kind of what I wanted to share about the Mini-Cog. Does anybody have any questions about that before we move on to the MoCA? So moving on to the MoCA, or the Montreal Cognitive Assessment. This test is a little bit longer than the Mini-Cog. It takes about 7 to 10 minutes rather than about the 3 to 5 minutes or 2 to 3 minutes, depending on how quick you are for the Mini-Cog. This is also in multiple languages. This test has variations beyond different languages. They have the MoCA test basic, which essentially is the MoCA test for somebody that has had 5 or less years of training, or somebody that you're worried about has psychological slowing for other kind of genetic or environmental or whatever the reason might be. They also have a MoCA test blind for patients so they can complete the test in case they can't see. The MoCA, when you're completing the MoCA, you have to be able to read, you have to be able to listen, you have to be able to write. And so the MoCA test blind does kind of help minimize those barriers. This test is 12 specific items. It's a total score out of 30 points. Kind of mentioned this already, but essentially there's an official training for the MoCA offered by mocatest.org. It's an hour-long training It's $125 for a 2-year certification, half off for future tests, and they do offer group rates as well. I just got their email. I don't have any affiliation with the MoCA test. This is the test that I use. I have not yet gone through the training myself, but I do plan to, so that I can continue to administer the MoCA test. But essentially, the MoCA test I find to be very helpful as far as helping me understand where the patient's cognitive issues arise, which domains, whether it be memory, attention, learning, visuospatial, executive function. The MoCA test has a lot more of those details versus the Mini-Cog, which really just tests visuospatial and memory. And so this is kind of what I was going to share about the MoCA test. Wasn't going to go through it in more detail than that. Does anybody have any questions about the MoCA? The last test I'm going to talk about is the 6-item cognitive impairment test, or the 6-CIT score. This is also a shorter test than the MoCA, only 6 questions, but 7 steps. There's 28 total points. This is an international test that's used all over the world. The other 2 are mostly used in the US and kind of Western European countries, but the 6-CIT score has a lot of validation data in multiple other cultures as well. These are the 6 questions. Essentially, the numbers in parentheses are the points associated with a wrong answer. So essentially, the higher your score, the worse you did, whereas the MoCA, the higher your score, the better you did. And so those are just kind of important things to keep in mind with these assessments, is they all score them differently. So essentially, what year is it? What month is it? Then you want to provide them an address to memorize. That address has 5 different components. Then you ask them about what time it is. You ask them to count backwards from 20 to 1. And then you ask them to say the months of the year in reverse order. And then once you go through all of those 5 questions, the last question is you ask them to repeat the address that you gave in step 3. You get 2 points for each of the 5 portions. If they remember all 5, they get 10. If they only remember 4 portions, they get 8 points. That's kind of how that one works. And so essentially, pretty quick test, 2 to 3 minutes, and kind of, again, has really good specificity. It really helps rule in dementia. But you may miss some dementia with this test because it's not that sensitive. Whereas with the MoCA, you're less likely to miss dementia, but you may over-diagnose it because it's not as specific. Any questions about the 6-CIT? So one of the last slides here is the limitations to screening. This is only a clinical tool, not a diagnostic instrument. The limiting factors include language barriers, education level, functional assessment, people having acute or chronic medical conditions, and cultural traditions. We've talked about all of these in kind of varying levels already. People with acute or chronic medical conditions, sometimes those conditions themselves, whether it be a stroke resulting in blindness or hemiplegia, can limit somebody's ability to complete one of these tests. Sometimes strokes can also cause aphasia as well, and so you have to kind of keep all those in mind. Making sure you do a good functional assessment along with screening. As long as people are able to take care of themselves and keep them safe, dementia shouldn't really be a limiting diagnostic in any respect until it really starts to affect their function, or essentially their ADL and IDL status. And if it's not affecting your ADL or IDL status, you definitely don't have a dementia because, as we talked about in the beginning, any issues with your cognition or your emotional abilities has to be bad enough to affect your quality of life or daily function for it to be considered a dementia. Before that, it's just mild cognitive impairment. And then cultural traditions too. I don't have any specific examples right now, but essentially I know there are certain cultures where you do want to be very careful on how you address these questions to the patient and their family, to making sure you're maintaining respect and transparency in what you're doing. So I think these are my references, so feel free to take a look at those. And that's all I have for today. Hoping that we had some cases, but what questions can we answer?
So we've got about 10 minutes left for questions or any patient cases that you thought of during the session. So feel free to unmute yourself with that microphone icon in the lower left corner of the Zoom window, or use the chat function to write it to us.
have a question.
Sure.
Are we able to access your slides?
Yeah, Troy will provide. We'll get a PDF copy on our website.
Yep.
Of the slides. Well, while you guys are thinking, you want to throw up the survey?
Yeah.
Before you guys leave us, we have a quick survey, a couple questions for you guys to fill out. It's anonymous, so we don't know who gives us the answers. It's true. But yeah, so if you just answer those couple questions, how many? 4 questions for us. We'd appreciate it. So while you guys are filling out that survey, we do have a new patient engagement series that we've put together for you all for the next 3 months for November, December, and January. November 19th will be our next one, and that's Tuesday at noon for effective strategies for patient engagement. And so we're excited for that one. Will Leslie be giving that one?
Heather.
Heather, okay. Heather Haslam, she's one of our partners at the Sanford Center of the Aging, for Aging. And so she's a great teacher, so we're excited to have her with us for that. And we hope that you can all show up. Please bring some cases for us too. We're excited to be able to help. I see there's a question. Yep. So once diagnosed, what do you recommend to the patient, family, living arrangements? Do you go straight to meds, further diagnostics? So that's a great question. Thank you for asking. So I guess I'll leave it up to anybody, any of the people participating to help answer Leslie?
Lindsay.
Lindsay's question. Sorry, Lindsay. It says Landon, so I'm getting confused. As far as what you would do once you're concerned about somebody having a dementia diagnosis, what are your next steps? Anybody feel kind of free to answer? We'll kind of open it up to the people on logged on first, and then we'll kind of open it up to the room here. So anybody in the room want to kind of offer their thoughts and opinions?
I'll pretend I'm Leslie.
Okay.
Meds would not be the first choice.
So Patty's pretending to be our pharmacist, who was not present today, and she was sharing that meds would not be our first choice.
I think the question I would want to know is, are there any concerns? And I would want to address those.
Yep.
You know, is it a living arrangement? Is it a behavior? You know, is there some sort of behavioral expression that's happening? Are they concerned that, you know, mom is driving? You know, like what are the families or patients' concerns?
Great. Yep. I agree. Yeah, the important thing is making sure you're maintaining a patient-centered care plan, a person-centered care plan. Dementia, even though it can be life-changing, it doesn't have to be life-limiting. Really, it's really how it's affecting them, and you want to address kind of those issues. When dealing with living arrangements, as long as people are safe and have family or social support, they can live how they want, where they want, and it's just really our job to educate them on the other options. And so I often, you know, and it's really a tough thing to figure out. We were just talking about this last week. When do you bring up that topic of, you know, you need to consider, you know, maybe moving off of that ranch into something a little bit smaller, or, you know, maybe you need to move out of that 3-story house into independent living, or lots of other different options that people take. And it's really kind of developing that therapeutic relationship for your patients so that when you do have to bring it up, they can trust you and they can listen to what you have to say, rather than them thinking that you're just trying to kind of make their lives harder and you don't respect them as a person. And so it's really about figuring out what's important to them and addressing that first, rather than kind of addressing some of those other things that are that can be important but potentially less important. Specifically about medications, I think it was Dr. John McCaleb gave us that discussion on kind of when to prescribe or de-prescribe dementia meds. Those medications are really helpful if you're kind of not in really the beginnings of dementia or the ends of dementia. Sometimes they can be helpful in preserving ADL function and prevent institutionalization or kind of having to move to a group home or a nursing home. And you kind of get a few extra months of that. And so those medications usually aren't very helpful, and they don't really modify the disease course in a significant way, except for those 2 ways that I mentioned. And that's specifically for Alzheimer's dementia, vascular dementia, Lewy body dementia, frontotemporal dementia, the other variants of dementia. There's not almost any evidence, and it's not FDA approved to use these medications for dementia. We often use them off-label, or they are often used off-label, but it really doesn't make a big difference in the patient's treatment plan, as far as I understand the evidence to show me at this point. But thank you, Patty.
And when would you recommend, like, not being a clinician, MRI or a CAT scan or some other diagnostic tool?
And so almost everybody that I diagnose with dementia, I give them at least a CAT scan to see what it looks like inside of their head. Sometimes a chronic subdural can present as a dementia, but head imaging is not routinely needed, especially if you get a really good longitudinal history over years, months to years of these changes without an acute medical event or acute medication change to kind of precipitate you. If somebody has other features such as hallucinations, seizures, things like localization of symptoms such as one side of the body or the other, with weakness or numbness or tingling, then I start to consider more of the MRIs of the brain. And then also depending on the subtype of dementia that you're considering, and so then I would refer you to the discussion last week where Dr. Hagan was talking about the different diagnostic criteria. And so lots of people with Parkinson's disease end up getting MRIs. But routinely, if you feel like you have a true Alzheimer's dementia, MRI at this point won't offer too much value until we have new therapeutics that may be 5 or 10 years down the line, as far as I understand it. What other questions can we answer?
Have you ever had cases where it feels like you have symptoms of more than one type?
Yeah, so great. Thank you for asking. I meant to say this, but I forgot. So often dementia, delirium, and psychiatric disease can all coexist at the same time. And so you'll have a mixed picture. Just like some people have a mixed dementia where they have a little bit of Alzheimer's type, a little bit of vascular type. Some people have a little bit of depression. Maybe they had schizophrenia their whole life, and now they're 70 years old and they're starting to have more memory issues. And so it's really tough to tell whether or not schizophrenia is playing a role or if it's a dementia playing a role, because lots of those symptoms can overlap because they have overlapping syndromes. And so you really just have to get that really good history and kind of make your best educated guess. In general, people's psychiatric disease, I'm not an expert in this, but in the general thing is they don't really exacerbate as people get older. They don't tend to get worse, requiring more like antipsychotics. They still require their antipsychotics, and so you definitely don't want to be stopping those abruptly. Often in geriatric patients, we like to avoid things like Haldols, aripiprazole, ziprasidone. But if they're being used to treat a primary psychiatric illness, we definitely want to keep them, and taking them away will likely cause harm to the patient. And so you really just have to make sure that we're still addressing that issue. Potentially, something like depression has reared its head again, and so you want to consider treating it as well. Lots of these things take time. You need to kind of make an intervention and reevaluate to see if it was effective, because we're doing our best educated guess when we're worried about a mixed presentation. Thank you.
Thank you.
What else can we answer? I think we have 2 or 3 more minutes.
Just still on my question.
Sure.
I had a patient where I work, and it just felt like the doctor struggled so much to really pinpoint what was going on with that patient. From what looked like sundowning to visual hallucinations to fluctuations in cognition, and then she was being so disinhibited. So, most times in treatment team, we're like, okay, what is it? Is it Lewy body dementia with the fluctuations in cognition and visual hallucinations? Then when she started becoming so disinhibited, it's like, okay, is this frontotemporal dementia? It was a little hard to pinpoint what was going on with that patient.
Yeah. So yeah, without more details, it'd be really tough for me to comment. In general, my approach whenever you have these kind of complicated things is, again, getting a good history. And so I tend to take a very medical history over the last, whenever it's appropriate. Sometimes it's a year, sometimes it's 6 months, sometimes we're lucky and it's just a month where they've had lots of changes. But you really need to figure out what was going on and what intervention they made and what that intervention did. And then kind of taking it by that step-by-step process. Sometimes I can kind of tease out what might have caused what based on my knowledge of the medications and the disease processes. So the first thing I would always think of are medications with a patient like that. Which of these medications could potentially be making this picture more muddy, more hazy. And then once I figure out how the medications may be playing a role, I then kind of start thinking a little bit more organically about the disease process. Because medications can just complicate things in a lot of ways. I don't know, do you have any other thoughts, Dr. Sharma? Okay. Yeah, so that's kind of general, is do meds and then kind of get that good history. And then sometimes it takes a lot of time and a lot of effort, but usually when people see you taking the time, taking the effort and figuring all those things out, you kind of develop a relationship. And so people know that you're trying and they're a lot more likely to report back things that you need to know at the next visit because sometimes we just miss, we tried this, but they never let us know it didn't work. And so we just assume that it's working, things are better. But that might not always be the case. Yeah. But that is our time for the day. We do thank everybody for showing up. Feel free to reach out to us if you have any questions between now and the next clinic. We're happy to help out. But if not, we'll see you next November for effective strategies for patient engagement as we start off our patient engagement series. Thanks, everybody.
Thank you.
Thank you.